Thanks very much for the introduction. I need to say that I actually still am at the University of Wisconsin-Madison, at least up until this morning, unless my dean has made a decision about that. As I get older, I'm more often standing between people and food, and so I want to assure you are going to get food after this presentation is done, but it's not for about another 40 minutes. But I want to thank the earlier panelists and have you recognize that within this panel, you've seen the plethora of perspectives. The staff and the committee members, as I tried to talk with us about bringing some coherence to our panel, appear to have stimulated richness rather than stimulated coherence, and so I hope you'll bear with us. My responsibilities today are to talk with you about innovations and certifications in the future. And I come to this from the perspective of a nurse, of an industrial engineer, and of a medical informaticist, all three of which are certified, credentialed, and actually licensed in some cases more than anybody should ever be. So we have many different discussions about what does this mean and why does it matter. My experience, very honestly, is that there are expectations, there are status indicators, and there are some financial considerations, all of which cloud the fact that we are fundamentally about ensuring to the public that we are doing about good and we are accomplishing what we say we are accomplishing. So fundamentally, that's where we're going. Now, technology brings in a whole different experience of care and of healthcare. And some of you have been watching me as I tweet away here. I think the experience of being at a meeting where we need conversation and input is so enriched by Twitter that I've been sending out some Twitter feeds about some of the comments that are being made, engaging nurses around the country a little bit and saying, hey, what do you think about this certification? Because we're talking about it right now here in Washington. I think this is important, but it changes the nature of what is a conversation because you don't know I'm talking to these people. They don't know I'm talking to you. All the rules have changed. And when we introduce technologies into healthcare, the rules are changing also. So the specific challenges related to certification in a knowledge management and information-intensive profession like nursing are really quite different than they are in other disciplinary areas where there's more biophysical or some psychosocial content to be credentialed on, because we need to understand, we need to apply, we need to discern, and we need to act. And as we change the tools that we have for knowledge management and the tools that we have to access the information for and about our care, we're changing what is available to both be credentialed about and the process with which we're credentialing on. So I want you to join with me for a few minutes to see my perspective of how I approach this idea. And some of you who've heard me speak before have seen this diagram that I use to describe a year in the life of a patient. The red line depicting a year of a person who's had an MI in January and processes through our healthcare system by the end of December, being quite a bit better, as most people are after an MI, because our therapeutics are so good. The person moves in and out of care delivery systems, in and out of contact with different professionals, in and out of contact with different parts of our care system, including imaging, pharmacy, rehabilitation. But notice in those very thin lines, that's where we almost always think about putting the microscope, putting the shining light to see, is the care good enough? And are the people who are giving the care good enough? And yet, as the patient experiences this, they move through this in the white spaces. We are a blip in their lives. And the emphasis on credentialing I'm calling for today must expand beyond the point at which a person encounters an industry to the point at which they encounter health. And as we think about our responsibilities as a profession, and as you and the various credentialing societies think about your specific work, you may still attend to what's in those slight narrow lines, because there are absolutely clear responsibilities for me as an individual, for my institution to be credentialed. But for patient-centered care, we need to move the concept of what we are credentialing beyond the institutional moment into the episode and the experience of the patient's life. This challenges us to think about data differently, it challenges us to think about practice differently, and it challenges us to think about what is the reference point for credentialing. Are we credentialing an individual for life? Are we credentialing a team for the moment? Was pleased with the conversation that I've heard so far today as we look at the interaction between a person being credentialed, a team coming together to provide care, and an institution housing part of that care process. I'm seeing a richness in the conversation of the credentialing discussion, moving beyond person versus organization to think about how do we address this highly vibrant and highly dynamic team structure as a point of care across a process in a person's life. I can't promise you that we have answers to this, but I can tell you that technologies, particularly the technologies that move with the person, allow us to do many things that we currently cannot do in our existing medical record structure and in our existing ways of thinking about clinical practice. I want to speak, as I focus my remarks, on two aspects: information technology and informatics focus on certification in the management of certification activities and in the substance of certification. Most of the conversation today has talked about the why and whether to certify. And information technologies can be of tremendous assistance in that. And you've heard from Rhonda's presentation, from Nancy's presentation, we have strategies to think about how to formalize data, how to bring it together in a trustable way, and to make interpretations about not only the certified nature of an entity, of a person or an institution, but also the impact of that. It's not simple, as we saw in Patty's model. She gave us some ideas about how we might bring together some test beds crossing institutions to begin to explore, does certification lead to better outcomes? And how might we do that in a way that is trustable? It's a terrific model. But if you listen carefully to what Michelle was speaking about earlier, she talked about interoperability being the key to making sure we had the data available for certification. And if we're going to think about the process of care across a number of different points of care, and certification for practitioners whose accountabilities now are extending beyond the walls of the little thin lines, we have to think about interoperable data from the beginning. Interoperability needs to be built in at the start, not attempted at the end. And our discipline in medical informatics has had fledgling steps towards this, some better than others. The urgency of meaningful use has derailed, frankly, some of the conversation of interoperability, and I'd like to see that get on with the work. To manage certification activities, though, we have a tendency to think about the organizational structures and information flows that we're already familiar with. And yet I've heard repeatedly today, and I read in the excellent paper that was provided to us as commentators, that's not working very well. And we need to rethink things that help people look at lifelong career patterns, not just employment in the moment. We need to think about licensure that transcends state lines, or perhaps certification that indicates our ability to participate in a team. I'd like us to advance, as I heard earlier this morning, the beginnings of a comment about certification of teams, not just of members of teams, so that we know this particular team is effective in the care of people with a chronic disease or in the care of families with kids with complex illness. Our certification to assure society that we have the right set of people in the right place to deliver the right set of care has got to reflect the care that we're giving. And our care is team-based, it's dynamic, and it's frankly has so little to do with the assignment sheet of the day. I heard several calls today, well, we'll just look at the assignment sheet, and I'm thinking back, now I'm old. I haven't touched a body since 1979 for clinical service. So it's a really long time ago that I did this. But I knew even then that assignment sheet of the day might mean that I'm responsible for these 6 patients, but somebody might go to lunch and I might get 3 more. Or I might actually have to step out to the bathroom and somebody walks into one of my patients' rooms. Or, in fact, I'm trying to mentor a new nurse, and so that nurse is giving the care, and I'm watching objectively. The challenge that we have of knowing who is with is actually possibly to be solved by different kinds of models of staff tracking and patient tracking, RFID sensors, individual implantable devices or wearable devices that allow us to know where people are, could be useful, but it will raise new questions that we have to discuss. So our management of certification activities, when we change the process from what we're familiar with to what's feasible, we will have to deal with new questions. Do you really want someone knowing exactly where you are all the time? I work in a building right now. We do stem cell and classified research. Actually, we have cameras everywhere. They know where all of us are, and I think somebody's actually watching us. Why? But they know what I'm doing. They could track the impact of my work on my student teaching. Maybe that's good. So as we use emerging information technologies to support the management of certification activities, think not only how to ensure that the technologies that we currently have available could be of use, but that the technologies of the future or even of tomorrow could be useful to us. Now, let me take just a few minutes to talk about the substance of certification. In preparation for this work, I looked a little bit at some of the prep exams for certification, and I just want to assure you, I'm not going there. You guys are all safe. I'm not going to take any of these exams, not even the informatics one and the engineering. Not going to do it. But I will tell you, I recognized almost everything that I read. And the last time I was in practice was in the 70s. What's happening to practice that's not being reflected there now? What kinds of technologies are we expecting? And what technologies transcend our certification areas? So interacting with an individual in a telemedicine encounter or a remote nurse call center brings a whole different mode to the interpersonal interaction skills or the knowledge management and critical judgment that we think people are applying. How do we show that in a certification strategy? How do we begin to take this practice of nursing, which right now remains under 70% in the hospital, and the rest of the 35% of us are out there doing something else? How do we get the certification to reach out to where we are? Importantly, how does the fundamental nursing practice change when a practice becomes mediated through technologies and affected through systems, through school nursing experiences who are trying to manage a kid recovering from a surgery that was actually cared for in a hospital, but the recovery of that kid depends way more on what that school nurse is doing than what that OR nurse was doing. We were asked to provide questions or challenges to you. And as a faculty member, I love this. Here you are. This is your assignment. If you can answer these by the end of tomorrow afternoon, I'll be really pleased. And you'll get points, because I've learned now when you use technology in education, you must give a point for everything that you do. So you will get points for these. All right, first of all, my challenge to you: care is becoming increasingly team-based and interprofessional. No surprise, that's already in the room. People get it. I'm thrilled to see that. But how can distributed data systems better characterize that practice and serve society? And this is a message for Dr. Simpson over there. How do we make sure we don't lose money by showing that there's teams involved in work? Because frankly, right now, our model of information is driven by our model of payment. Second, sorry, Patty, but I think it really is. Secondly, how does credentialing change in an era of patient-centered care? Really, if we're saying that the patient-centered care gives the patient a say in the care, then shouldn't they have some kind of say in the credentialing process and what's considered a good outcome and whether or not they like that outcome and whether or not that was the outcome they wanted? Third, what is the role of patients, for example, in patient-reported outcome measures in the credentialing process? I was really pleased to see in Nancy's description of the way to build measures, these variety of data sets were intended. But I will tell you, these patient-reported outcome measures are never going to be in the EHR. I mean, I sat through that last year with NQF. It's not going to get there. It's going to be somewhere in the cloud, and that's not a bad place right now. But we have to think about, if we're going to engage patients in helping with the credentialing process, we've got to figure out, how do we do that? And we can't, by the way, their time isn't free, and we can't keep asking them one more survey and tell us what you thought of the nurse that you thought was taking care of you. And finally, can effective use of health information technologies lead to a more nimble certification cycle? And this goes back to something that Jack was saying earlier. At some point, we decide that a team or a practitioner or a process is stable enough that it merits certification. But yet now we are constantly reconfiguring all the time. It's not just in trauma or in disaster relief, but in clinical units, the traveling nurse model, the number of times we have different trainees coming through means our teams are always in flux. And at some point, the certification conversation has to address that group. So I leave these for you as an exercise over lunch, and I thank you for your time.